Welcome, everybody. I hope everyone's keeping safe and well. This is our 12th webinar in a series on the Work Disability Management System Standard, the CSA Z1011. And today's session, we are going to focus on healthcare and disability management services, or experts in the work disability management process. This is our second to last webinar in this series, by the way. So the agenda for today, I'm going to start off with a high-level summary of the standard and then give a bit of a focus on healthcare and disability management services. And then we'll get into our panel conversation with our panelists, where we have some questions and comments for them to speak to. And we'll also be taking questions and comments from the audience at the same time. So we'll try to insert them into the conversation as the questions arise from the audience. So please feel free to ask your questions in the chat function or in the question and answer part of the webinar format as well. So these are the speakers for today. Myself, I'm the director of the Center for Research on Work Disability Policy. We also have Alec Farquhar, coordinator, Asbestos-Free Canada and chair of engagement for CRWDP. He's one of our panelists. And then we have Behdin Nowrouzi-Kia, another panelist who's assistant professor, occupational science and occupational therapy at the University of Toronto. And then our third panelist is Sousa, who is the executive director of Ontario Occupational Health Nurses Association. So on this slide, I have an overview of the technical committee that developed the standard. I was the chair of the committee, and we had two vice chairs, Emile and David Brown, and the CSA project managers were Lena Lopez and David Shanahan. We had 26 voting members and several non-voting members that comprised the technical committee. We tried to have representation across all of the key stakeholder groups in the work disability policy arena. So we had a number of employer representatives, labor union and injured worker, disabled worker representatives, health and safety professionals, some return to work specialists, experts in work disability prevention. We also had some work disability insurance program providers and a number of academics and researchers, including myself. Here I have a list of the technical committee. I won't go through them all, but I've highlighted the three panelists today. They were all part of the technical committee. So Alec Farquhar, Behdin Nowrouzi-Kia, and Drew Sousa were key members of the technical committee. So it's great to have them here for this panel. So the purpose of the standard, it's meant to provide a consensus-based framework for the management of work disability at the organizational level to address both physical and mental health needs of workers. It's relevant for the management of both work-related and non-work-related health needs. And it also includes consensus-based guidance on the recruitment, hiring, and onboarding of workers with disabilities. The standard also provides some supporting materials in the form of annexes to the standard, including some implementation tips. And we're actually going to drill down on one of those annexes that's about expert contributions to the work disability management process. Okay, so the standard really emphasizes the systems approach to work disability management. Traditionally, organizations don't take a systems approach. They tend to address work disability management in a slightly different way, where they focus it as a person's role, possibly a manager within human resources or within the occupational health and safety department if the organization is larger and does have a standalone occupational health and safety department. They often handle workers' compensation claims separately and differently than non-work related injuries and illnesses because they're different programs. Some organizations even treat it as an administrative function, which they farm out to an outside organization to deal with handling workers' compensation and non-workers' compensation type work disability management issues. As a result, they often take a reactive approach to evaluating the performance of their work disability management system. They often look at absence days to see if they're doing well in terms of their performance of their system, but those are really lagging indicators. It's really a reactive approach when you're really looking at managing absence days. Converse to this approach is the systems approach, which is promoted by this standard. It's a proactive approach that considers roles and responsibilities across the organization, because work disability management, everybody plays a role within the organization. It considers inputs, process, outputs, and feedback, and evaluation and improvement on a continual basis. This is a really, really critical part of the systems approach. So many people have asked about what is a management system, because maybe it's a new term to many people. All organizations do manage their core activities in some way, whether informally or informally. So whether or not they use the terminology of management systems, they do have a management system to address their core activities. Preferably, though, an organization has a formalized framework of policies, processes, and procedures to meet their core objectives. Really, if we have a formalized process, it's more of a tested step-by-step method, really aimed at smooth functioning through standard practices. And audits also play a really vital role as part of the management systems approach, because what gets measured gets done. So really auditing and evaluating performance is critical to an organization systems approach to managing their core activities. And ideally, an organization has a framework in place to address all its core activities, including work disability management. So this systems approach to work disability management really ensures that there's clarity, consistency, and integration with all the other organizational activities. This standard actually promotes a proactive approach to addressing health needs of the workers as they arise before they become disabling. And sometimes we actually use the vocabulary of work disability prevention to address the notion of being proactive in addressing health needs so that they're not disabling. Whether health needs arise from exposures at work or elsewhere, being proactive around addressing those health needs on a timely basis is really critical. So the management systems approach is organized around, at the front end, some policies. And so policies play a fundamental role in setting very clear directions for the organization to follow. And then the next step would be organizing those policies within the organization. So having management structures that are needed in place to deliver on those policies. There's also then planning and implementation, which is required to be systematic with implementing those policies. The measurement and performance evaluation is really critical as well. It emphasizes that given the measurement of performance against targets to identify needed improvements is really critical. And then reviewing and learning from experiences are also fundamental to that continual improvement process. Once you meet those targets in a particular cycle of that continual improvement process, you may want to then go back to the starting point and identify some incremental targets that you want to reach and do that cycle a second round. And that notion of continual improvement is always looking forward, thinking about how we can do better in what areas to prioritize and set new targets to achieve over that cycle. So the standard, the CSA Z1011 standard, has 6 guiding principles. The standard promotes an evidence-informed, data-driven approach that is strategic in nature. It really promotes a focus on inclusion and accessibility to ensure that workers are engaged and feel that they belong. It also promotes a worker-centered, supportive approach that is contextualized and case by case. It promotes accommodation and early return to work that considers the worker's essential duties within that organization. It also promotes a joint responsibility between the organizational management, the worker or workforce, and the worker representatives where applicable, and legal compliance as applicable within the jurisdiction where the organization is situated is a starting point for this standard, because this standard is a voluntary standard that takes you over and above the minimum requirements of the law. In this slide, I have an overview of the content of the standard. There are 7 chapters, as you can see, starting from 0, the introductory chapter, and then 4 core chapters where are identified in highlighted text 4, 5, 6, and 7. I'll give you a bit more detail in the subsequent slides about the content of those 4 core chapters. And then there's a number of informative annexes, and we'll be drilling down on Annex B, the role of experts. So I'll give you a little bit of background about what's available in Annex B. So here we have an overview of the 4 core chapters. It's framed around that continual improvement process. So plan, do, check, act. So chapter 4 is about work disability management systems. And that chapter really emphasizes the involvement of all key stakeholders being really essential. Everyone plays a role, as I mentioned earlier on. It ensures that the foundations are in place to go forward with your planning cycle. The planning chapter, chapter 5, emphasizes the need for the organization to understand its strengths and identify areas for improvement to help identify appropriate targets for that cycle. And then chapter 6, which is about implementation, emphasizes the importance of a well thought out plan to achieving success. And then finally, Chapter 7, performance monitoring, evaluation, and continual improvement really emphasizes the importance of performance measurement. What gets measured gets done. So Annex B, I'm going to drill down in the next three slides on Annex B, the role of experts. There's three modules in that annex. The first module is about just a general background about the role of experts, and it notes that healthcare professionals and other experts will often be involved at various points in the case management process. Experts can be retained by the person with a disability, the organization, the insurer, the workers' compensation board, or some other participant in the work disability management process. Professionals may be consulted about crucial issues of disability and accommodation. So the key principles that are noted in this annex is that the ultimate responsibility for work disability management really rests with the organization according to human rights legislation. So unless otherwise mandated, the organization's responsibility is to reasonably accommodate the worker with a disability using the findings of experts as input. So accepted human rights principles is that the approach to accommodation really should be the same regardless of the program or context. So whether it's an occupational injury or a non-occupational injury, the principles of accommodation are universal and apply for both kinds of situations. A qualified case manager might also be required to assist all the parties involved. And then finally, the third component of this annex talks about guidance to workplace parties. So the organization's systems should include a standardized process for dealing with healthcare professionals and other experts. It really needs to scope out information requested from experts and should be based on specific organizations' programs. And the request should include consent forms and clear communications to the worker about how that information is going to be used. And ideally, the organization has developed physical and psychological demand analysis for each of the positions with the organization because it really can help serve as a basis for evaluating information on the worker's limitations against the job requirements and help identify possible accommodations that might help fit with that worker's capacities in order to get them back to work early and safely. So those are the three modules within that annex, and we're going to drill down a little bit more about these annexes with our panel conversation that I'm going to start up just shortly. We're going to start off with some bios from our three panelists. We have Alec, Farquhar, Behdin, Nowrouzi-Kia, and Sousa. And I'm not sure if all of you want to turn on your cameras, if you'll do so now, if you're comfortable with that. And I'll ask you each, starting with Alec, to give you a bio of yourself, and then we'll get into our panel discussion.
Hello, everyone. I'm Alec Farquhar. I'm a lawyer, and I've been involved for a really long time with disability and employment issues, starting as an injured worker advocate, and then in various jobs, including at the Ontario Workplace Safety Insurance Board. And I'm very proud to have participated in the development of the CSA standard. It was a long-time dream of mine to include this standard with the other CSA health and safety standards. And also in the work of the Center for Research on Work Disability Policy and the big coalition we're part of called Disability and Work Canada. So I'm really trying to move these issues along, and it all starts in the workplace.
Thank you, Alec. Behdin, do you want to give a bit of bio?
Sorry, can everyone hear me?
Yes.
Great, thank you. So good afternoon and good morning, everyone. My name is Behdin Nowrouzi-Kia. I'm an occupational therapist and also assistant professor at the University of Toronto. I've worked in the area of disability management, work disability prevention as a clinician now, probably close to 15 years. And more recently, I've moved into academia and do research in this area as well. And I also am very proud of the team and the technical committee's contributions to the standard. I think it will go a long way, and it's quite at the vanguard of research in the area of work disability prevention, and really excited to be able to share this virtual platform with my esteemed colleagues.
Thank you, Behdin. And Drew, I know you're not going to turn on your camera, but can you give us a bit of bio for you?
Sure, no problem. Yes, you'll forgive me. I'm having some technical challenges, so we'll just keep the camera off for now. So my name is Sousa, and I'm the Executive Director for the Ontario Occupational Health Nurses Association. I represent the largest group of occupational health nurses in Canada, and we are very involved in the day-to-day work that happens with the disability. with disability within an employer or an organization's workplace. Personally, I have been involved in disability management for between 25 to 30 years. I recently left a large organization where we managed a team of over 10 individuals in the disability arena from a variety of different backgrounds. And I also am very proud of all the work that was done with the standards, and hope that it will end up becoming as a critical a standard as some of the other excellent ones that come from the health and safety arena. So I'm very glad to be here. I look forward to the conversation.
Great. Thank you all. And so I'm going to start off with our first set of questions. I've shared this with you already, and I'll just note for the audience to, if you have any questions, please do put them in the chat box or the questions and answer box, and Sabrina will be moderating them and insert them into the conversation as appropriate. But we'll start off with our first question here for the panelists. So the first question is about what is the role of experts in the work disability management system? I've given a bit of background about that, but I thought maybe you guys could elaborate about it and just think about how that role might vary if you're working within the organization versus an external expert. You know, what is the difference in those kinds of roles? You know, and does it vary by program? Because we know there's a lot of different programs that come into play here: workers' compensation, you know, private insurance, maybe just general sickness absence that it's covered by the organization itself. And then, do you have any suggestions on the various ways an organization can best manage those expert contributions to the work disability management process? So I'm not sure if either of you want to jump in first, or should I appoint somebody to start the conversation going? Alec, how do you feel about it?
I'm glad to start. I've had a tremendous amount of experience with the involvement of experts in work disability management in workplaces, and I've got pretty strong views on it. I'm so glad there's an annex to the standard that deals with this, and Drew and I, maybe some others, contributed to that, and the annexes are tremendously important. So don't ignore them when you're reading the standard. Mm-hmm. Something that's all too common is that workplace parties abdicate their own responsibilities to the experts. Maybe they lack confidence in dealing with significant disability issues. Perhaps they don't have the time or energy. There are various reasons this happens. And the problem is that the experts are often not that familiar with the workplace realities, so you'll sometimes get solutions that won't really work. So I really strongly advocate that the workplace parties take on their full responsibility for a proactive, progressive, inclusive approach, a worker-centered approach to disability prevention and management. And then they include the experts in that with the tremendous value that experts bring, but don't just hand it all over to the experts. So I'll just sort of start with that and see what other people think.
Hi, it's Drew, and I fully agree with Alec. There has been a perception that you can outsource this responsibility. The reality of it is you cannot. As an organization, regardless of who you bring to the table to help manage disability, ultimately, it's your legal and as well as, in my opinion, ethical responsibility to ensure that you have a consistent approach. And so I always look to say, it really depends on who you've hired as your experts, what their qualifications are, and what the mandate of your program is. So one has to take a look at really starting the conversation is, what is the purpose behind your program? And then who have you hired to support this program? If you've got the key individuals in-house with the kind of medical expertise that's required to appropriately interpret the information, right, then you're less likely, in my opinion, to fall into some challenges. If you're responsible for bringing in those experts as required, then you have a responsibility to ensure that that those external experts who may not be as familiar with the programs that you have in-house, right, that you direct them accordingly. So I really think that the level of expertise is dependent upon the purpose behind your program, and then the nature of the work being performed by those experts is dependent upon how involved they are. If they're very familiar with your program, because they work internally and they know you and they know the organization, then it's a much smoother transition for the individual. If on the other hand, they have a vested interest in maintaining, you know, your relationship because it's a fee-for-service basis, then you have to be a little bit more direct in the way you manage it. And frankly, the best way of managing an external expert is to ensure that you have a very clear performance agreement with them that clearly outlines your expectations, and that you can, I'm going to use the term, challenge them on an ongoing basis regarding any of those individual cases that they're managing for you. I would tell you that the folks who assisted us in the organizations that I worked with knew my voice and my phone number whenever it came up, because I regularly had very lengthy conversations with them regarding my expectations, right? And we held them accountable. So that's my opinion.
Behdin, now you've served actually as an external expert, I'm guessing.
Yeah.
So you probably have a sense of it from another perspective. So.
Yeah, that's actually what I was going to add to it. I think I agree with everything that's been said. You know, coming in from an external perspective as somebody who's brought in to bring expertise, particularly from the healthcare perspective, I think that's the number one situation that I encounter is one where there's a breakdown in communication. So I think if that communication is clear from the internal stakeholders to those that are coming in, and if that external expert, for example, has the expertise as a regulated healthcare professional and has an opportunity to engage and to understand what's going on within the organization, and that communication is clear and I would say fairly frequent, you will find that there's less barriers. There is less opportunity for things to go sideways. And I think that's quite helpful. And I think the other piece that I would add, and it goes back to the standard that we're speaking about, is that the focus should be on the individual. So we want to talk about an emphasis and an effort that looks at it from a person-centered perspective or a worker-centric perspective, one that essentially puts the individual in the middle of the conversation or at the center of what's going on. To an extent, from my discipline, we consider them to be the expert on their health and well-being, and that as experts, whether we're internal to the organization or external, our role is to essentially to support them, to provide our knowledge in specific areas, but really to listen to them and ensure that they are heard. And I think that's very important. And finally, to just add that we want to look at this from an individual case by case or person by person perspective. I don't really like using the word case very much. I like to humanize it and use the individual or someone's story. Everyone will have a narrative, and we want to listen to that. And wherever we land as experts is to ensure that those stories are heard and that we appropriately support these individuals in whatever types of situations they're encountering in the workplace.
I'm glad you used the person-centered approach vocabulary. That's really interesting. Sorry, Drew, were you going to say something?
I was just saying, I totally agree with Behdin's statements. And I think what's equally important to understand is that you can't abdicate your responsibility as an organization to that individual and ask them to be held accountable to a poor program, right? And sometimes that's what I find happens when you bring in an external expert. You're asking the expert who tends to be person-centric, because that, especially when they're regulated healthcare professionals, right? But the challenge is that if you don't hold a good program in place, if there's not a comprehensive program at the organization, then the regulated healthcare professional cannot do their job properly. And that's what's exciting about this standard, is that it's telling the organization it starts at home. You make sure you have the framework, and then of course bring in the resources as required, right? So absolutely, I totally support Behdin's and Alec's comments.
Mm-hmm. Can I just ask a question though? What would you suggest for small organizations that don't have a lot of resources and probably not a lot of expertise internally? How can they manage these processes to make sure that they're getting the best out of the experts that they do consult externally? Alec, do you want to start?
That's a really good question. I imagine there may be at least some people on the call who are asking themselves the same question. They don't have a lot of resources, especially in the COVID-19 environment. And yet, what Behdin and Drew have said really still applies, even if you're relatively small. when you encounter a disability issue, you'll probably lack the detailed kind of process that a big place has. There's no question of that. You probably won't have anybody in-house. But you still are in a relationship with that person with a disability. They've disclosed to you, maybe they've gotten hurt at work, maybe it's something that they've had for a long time that's getting worse. It can be a whole range of things. And you want to do everything you can to help them succeed in continuing to work with your company or your organization. In that kind of situation, a recommendation I'd have is you can use that expert, if you get a good one, who's person-centric, as Drew and Behdin have been saying, and maybe use them to help kickstart your approach. So not just a bit of advice at a moment in time on that specific case, but how to strengthen your response over time, because the expert will not be on site every day that this worker is coming to work, being accommodated and issues coming up. You're the one who's on site. They're a colleague and perhaps a friend of yours who you really want to support and you really want them to succeed. So you can use an expert to help you frame your policy, even when you're really on a small scale. And the best of these consultants and medical folks, they love doing that. They love helping raise the bar at an employer because they know they're leaving behind a lasting legacy. They want to do it.
Thanks, Alec.
May I just add that I agree with Alec what has said. In my experience working with SMEs, particularly in remote or rural in Northern Ontario, has been quite very similar to this as well, is that they may have an opportunity to engage with an expert, usually externally, for a period of time, and then to utilize that opportunity to essentially leverage their experiences, their expertise. And now that this standard is available, to align that with what's recommended in the standard, because it can apply to all workplaces of whatever the size of the organization is. So I think it's really giving you an opportunity to have a guideline, or if I can call it maybe a blueprint, that you can look at, and not to be intimidated because you're an SME or one that you say, well, I don't have the means to do it. Now there's really an exciting opportunity, as Alec has said, to engage and to use that expertise and to align it with what the standard is offering.
Thank you.
I also agreed. My only suggestion would be when you're looking for that external expert, look within your current relationships and see if there's somebody that you can utilize. So I'm going to use as an example, you know, your insurance company, your EAP provider. So see if there is somebody who currently you've already developed a relationship with and that you're having an ongoing relationship, who knows your organization, and you're maybe asking them to extend beyond that role that you currently have with them, right? And when we're talking about you know, external or experts, we are referring to individuals with disability background, either at the work site or are independent of the work site. So we're not necessarily just talking about independent medical examiners, right? We're also talking about the insurance company's experts. We're also talking about experts that you bring in when you have a more challenging case, right? So.
Yeah, thank you. And actually that dovetails very well with the question we have from the audience. Someone notes that I work in disability management with a large insurer. Have the roles of the private insurers been considered, as it is never just the employer interacting with experts?
And I think that's what I was referring to when I said my external parties knew me very well, and because in my opinion, when you have a contract with an insurance company, they have a responsibility to fulfill that contract, but they also need to know as to, you know, what was really the intent behind it. So some of the language in the contract precludes certain activities, but if you have if they understand their client, understand their intent, then there's opportunities to do some stretch, I would use. And so, yeah, I had regular conversations with my insurers who may have been, you know, the direct contact with the independent assessment, but my expectation was that they managed that relationship. And in many ways, quite frankly, I considered myself as an extended member. I considered the insurance company an extended member of my team, and we worked together collaboratively.
Fabulous. Behdin or Alec, do you want to add?
Sure. I think this is a really important point, and in a number of ways. The insurer, essentially, they're retained, usually through a competitive process by an employer, to provide a certain level of income support. So usually this would be in a situation where it's not a workers' comp case, where workers' comp would be in the mix. And there's a premium paid. So in a sense, there's a partnership here. The insurer has to get a certain level of income to provide the service it provides. But if the workplace parties don't do a good job, the cost of especially long-term disability can just skyrocket. Mm-hmm. It can become a factor in bargaining. Literally, if it goes up 2, 3, 5, 10, 20% or whatever it might be, that makes bargaining tighter for other benefits that a union might want to acquire for its members. Or even in a non-union environment, it's taking away money from other things. And so I believe all parties have something at stake here that's often not really noticed, which is the better job you do at accommodating disability, both in initially recruiting folks with a disability and being ready to receive and support them, and then later on, if a disability emerges, the better you do at that, the less important, in a sense, the premium for long-term disability becomes. I've seen some extreme situations where the amount of money being paid on long-term disability was literally threatening the viability of an enterprise. It was that bad. Mm-hmm. Like 10% of the workers off on long-term disability. If you can fix that and make that program more integrated and understood and make the workplace relationships better, it can affect labor relations, it can affect the trust employees have in the employer, it can affect your bottom line, your productivity, the engagement of employees. So there's a lot in the mix for this. And the worst of all is when the insurer is way off at arm's length and every once in a while seems to almost swoop in and not connected with the experts, not connected with your management of workplace disability. So you really want a good virtuous cycle to be going here.
Thank you. Behdin, did you want to add anything?
Sure. Only to add that I think what I've heard from the other panelists is that, you know, ultimately we're talking about communicating with people, communicating. If your role is as an insurer, as the question was raised, or others, is that you want to have those open lines of dialogue. And I know it will lead to our conversation about case management to an extent, but to be able to do that, and if you have this opportunity to engage, ultimately what we're all working towards, every single person involved in these types of roles, is that we want to ensure people are accommodated, they're safe at work, they're able to return to work or engage in work activities in a safe and healthy manner. So I think all of this is that we want to work together. It might seem very Pollyannish of me to say this, but it goes a long way if we keep that in our mindset, that we do want to work at the same level and we want to work together on this.
Absolutely.
I have a question about just the different types of programs that are out there, because it's come up in the conversation, workers' comp, private insurance. How does an organization manage those things? They're very different programs to make sure that there's, as best as possible, kind of consistency in how you address a person's health needs.
So I'm going to give you my experience, and I, quite honestly, my team, it didn't matter if it was occupational or non-occupational. At the end of the day, the rules mattered in terms of there's certain expectations, but from an employer perspective, it didn't matter, right? So who paid you was one situation, but how we dealt with you and the manner in which we dealt with you and the fact and the opportunities we provided in terms of accommodation made no difference whatsoever. And that was an essential element of developing the trust that was required in order to have an effective work disability program. Because if you're treating people differently based on the reasons that their absence, the reasons why they're absent or who's paying them, then you cannot develop the trust that's required to have an effective program. So it made no difference whatsoever.
Thank you, Drew. That's helpful. Behdin or Alec, you have anything to add?
I could add a little bit here. I really agree with what Drew said. this is a really important point. It's not just a technical legal type point. If you're really trying to bring a transformative approach to disability into your workplace, and if you think about what we've gone through the last year, coming back from this, we want to include everybody. A lot of workplaces, a lot of people in workplaces have been traumatized. A lot of companies are literally wondering if they'll survive the next 3 months. So in that kind of an environment, you want a deep, systemic, proactive approach to disability. And if you start sort of slicing and dicing it based on what program the person's part of, I think it's a real mistake because it interferes with building the kind of culture and practices that we intended to bring in with the standard.
Yep.
Thank you. I just wanted to read out about somebody's comment here. It's not a question, but I just thought I'll read it out here for everybody to appreciate. So I just wanted to say I agree entirely about the importance about the collaborative approach here. Alec's comments about the effects of having the insurer swoop in from some remove in the process, working against the required trust in the relationship really resonates with me. So just reinforcing what you guys have been saying about that building that trust is really critical. Let's move on to the second question about case management. So that's a vocabulary that's used in the standard in this annex. And some people may not know completely what that entails. So I thought maybe we'd start off of just getting some background insights on what's meant by case management and does it apply to all situations, both work-related and non-work-related illnesses? And maybe give some examples of case management, how it differs maybe for different health conditions, such as mental health versus physical health. Do either of you want to start?
I can make some comments really quickly. Case management can be a code word for some people. So there's probably people on the call today who are thinking case management means a technical approach that is the employer and its representative, like perhaps their disability management person, distancing themselves arm's length from the person with disability and managing them as cheap as possible, doing as little as possible. So case management, I believe, for some people, it has that content to it. And I want everyone to know that is not what we mean here on this call by case management.
No.
We really mean devoting all the time, resources, and support, especially at the front end, especially as proactive and early as possible, to working with everybody. So I'm going to stop there because I'm not a case manager in that sense. I know Drew, maybe Behdin have more experience in that than I do, and we'll see what they have to say.
Drew, do you want to jump in?
Sure. I guess when I think of case management, I'm looking at the term as meaning you're not just dealing with this particular absence in this period of time. You're appreciating and understanding what the condition the individual has means to the overall impact throughout their employment cycle. Right? So that starts from hire to retire. And that was part of the message that we had throughout the standard, was that this isn't just about talking, oh, this particular incident, this moment in time, what's the impact to our workplace, but really what's the impact to the individual regarding their disability, and how are we going to support them from the time that we hire them, right? And as they transition in their career to different roles, and as they have peaks and valleys in their condition, which require additional support or not. Right. And that's why, in my humble opinion, case management is really the responsibility of the organization, because whomever you hire is there that moment in time. Whereas an effective case manager understands the person and is going to be there with them as they move through their career. And that's more likely to happen within the organization as opposed to externally, you know. And again, that's just my humble opinion. And that's the kinds of programs that I have seen to be most effective, is appreciating that there's a lot more to it than the incident that you're dealing with.
So if I understand correctly, are you suggesting then that case management is done within the organization?
I'm suggesting that case management is an essential element and that somebody within the organization should facilitate that process. That's where I've seen it be most effective. Again, because it isn't about the single occurrence that you're dealing with. It's about the whole, the premise of that condition and the impact of that person's condition on their employment as a whole, right? And you know, and that's why, you know, if it's again, in my opinion, it includes things like managing attendance, managing performance, all of those elements, because that's a reflection of the work disability, right? The impact to that. And that's why sometimes, you know, case management tends to be limited to the more complex situations, which is appropriate, except I think sometimes you lose sight of the fact that if you don't put a lot of these incidental absences together, then you're losing sight of the whole picture. Right. So when you're talking about when should it be used, it should be used all the time, regardless of the nature of the condition and regardless of the length of the absence. Somebody's got to be looking at the whole picture. So it's that biopsychosocial as well as the work cycle of the individual.
Okay, thank you. Behdin, do you want to add anything there?
Yeah, sure. To add that, I think the case management perspective, to echo what my other colleagues are saying here, is that it's pivotal that it's used throughout the organization. It's pivotal that it's sustained and it's engaged. It also demonstrates the engagement that the employer, for example, has for their relationship with the employees and you know, unions or associations or other allies as part of this conversation, because it shows that there is a willingness to collaborate and work together on this. And I think, you know, success, and when I've come in either as an external stakeholder to agree with Jude, that's what I've seen the greatest successes being that there's trust, there is good working relationships between all the different parties that are involved, is when there is that emphasis put in internally on the case management process, and to have people that are have expertise in it. And it can come from very different backgrounds. I'm a proponent that certainly healthcare regulator professionals have this as part of their training to become medical experts, but also you can get it elsewhere and then complement that training. And then if you don't have the expertise, to seek it out in certain areas. But I think if it's integral to the internal organization, and it's helpful to have that there.
Great, thank you. Can I ask you guys maybe to speak a bit about mental health and case management and with mental health conditions? Because obviously that's on the rise. It's a big concern for many organizations. It'd be nice if you guys could give some guidance in that area. Al?
Maybe I could start on that. It's something I'm passionate about, and I imagine for a lot of people on this call, it's top of mind right now, given the context. Mm-hmm. I think that the approach in the standard is most important for mental health conditions than to any others. And my reasoning is that mental health, I think more than any of the others, is even more about relationships, trust, dialogue, support. It involves the coworkers. It involves someone disclosing or manifesting something that may make them deeply ashamed. They may be afraid of exposing it, often crosses over with substance abuse issues. So you've got a person who's in a vulnerable situation, and of course, who has tremendous potential. So you want to have a culture in your workplace and a whole framework, as the standard tries to establish, where that person will feel safe with their supervisor in particular, and also the experts that might be in the workplace, and the insurers and everybody else, all the parties, the union, disclosing, opening themselves up to a difficult situation, not being stigmatized, getting the support they need. And I, in my whole working career as a manager, I'm most proud, more than anything else, of the relationships I built with some folks who were struggling with mental health issues, who rebuilt themselves and brought themselves back to a full functioning situation. So there's tremendous gains for everybody. It's also a financial gain, because mental health is costing so much right now in disability programs. So it's just vital to learn a lot about it, be supportive, build trust, and there'll be a payoff in every way you can think of.
Thank you. Drew, did you want to add anything?
I would just say that, you know, recognizing that when it comes to statistics, what I understand is approximately close to 50% of all extended absences are related to mental health issues. That in itself tells you that, you know, this is a huge issue. That, in fact, if prior to COVID, I would have said to you, this is the pandemic, mental health. And it doesn't work unless you use an effective case management process, because those of us who work on cases on a regular basis recognize that there's ebbs and tides, more so in the mental health conditions than there might be with physical. So you have to be taking a look at the whole comprehensive picture here. And to Alex's point, if you haven't been able to build that trust, and if you don't have a supportive work environment, then you're not going to be successful. So case management is a key foundation within any return to work process, but especially one where there's a mental health issue at play. And I also want to mention, before I forget, that an equally important, and this is where case management, this is where sometimes the hands of the case managers are tied, is when you don't have a comprehensive accommodation plan or program in place, right? So, you know, we talk about case management, and it's absolutely critical to it, and it rounds it all up. But at the end of the day, if you don't have a appropriate accommodation program in place at the employer's workplace, case management will not be as effective as it can be. And that accommodation and that strong accommodation program certainly will be critically important to individuals with mental health issues.
Great. Thank you, Drew. I still have a couple more questions for you guys, so we're not done yet. So what is the purpose of physical and psychological demands analysis? We use that vocabulary in this annex. And if you can give a bit of background, because it may be new to some organizations, particularly small and medium-sized organizations, and then suggestions for organizations of how to get started down this path of having these kinds of demands analysis completed. I'm not sure who wants to start there. Alec, is that something you can speak to?
I've had a lot of experience with this, and it's another really good example of something in this field covered by the standard that's often considered of secondary priority and as sort of a tick box type technical exercise. And nothing could be further from the truth, because maintaining a really good concept of the physical and psychological demands of jobs in your enterprise is just at the heart of a lot of what we're trying to do, because it's saying to you as the employer and to your workers and in collaboration with your union, this is what jobs here are really all about. So just think about the job in a supermarket the last year. What's that job really been all about? There's been tremendous stress in that job. Literally, you go to work risking getting sick, and it maybe hasn't been thought about in that fashion. So reviewing your physical and psychological demands analyses is important, but also making them living within your enterprise. I personally say review them every year, talk about them with your union, talk about them with the employees when you're doing your performance planning and your unit planning, etc. Really understand them. And when you really understand them, that's when you can look at creative approaches to accommodation of disability and surprising different ways of getting the work done versus a sort of rule-bound technical approach.
Thank you. Thank you. Drew, I imagine you've had a role in these kinds of analyses. Do you have something to add?
Well, I think it's important we make sure we get Behdin in, because I know that his background is probably has been much more involved. I can tell you that the programs, when we decided to prioritize how to put together PDAs, we did it based on a couple of really simple factors: multi-incumbent positions first and foremost, and then secondly, positions where as they were required. So there is a way of doing it cost effectively. But as I say, I'm going to ask Behdin. I know because of his background that he'd have a lot more to add to this.
Okay, go for it, Behdin.
Oh, thanks very much, Drew and Emile. Yeah, so you know, to add a couple of things, I'll tie it into my mental health comment as well. Yeah, in terms of the job demands analyses, I think it's pivotal what we heard about the frequency of how they're done, why they're important. They really give you a picture of what it is that's involved in specific tasks for that particular job, and how does that link to the individual? How do you make the individual and the task fit well together, and how does it come together ultimately to create healthy and safe workplaces? When we look at the mental health environment and what's going on, particularly with the pandemic, we had this tidal wave of mental health issues and claims that have only been accelerated because of this pandemic. And now what's referred to in the academic literature as the fourth wave, or that mental health wave that's going to follow up once this acute phase of this once in a generational pandemic is past, is that we're going to see the complexities of mental health rise. And we're going to see individuals talk about how difficult it is, for example, to engage in their work because of the mental health challenges. And to recognize that from a job demands perspective, when you're doing, for example, a mental health evaluation, that these are opportunities to recognize the episodic nature of certain mental health claims, unlike physical health claims, which may be much more of a linear manner, so that someone could have a good day and a bad day. And how do you incorporate that into the conversation if, for example, you're a supervisor and you have an employee that just seems off, if I can use that language, or that how do you engage with someone if you don't know where to start? And these are simple ways that, I've heard from individuals say to me, I don't know how it is that I would have this conversation, or it seems really difficult to talk to somebody about their mental health, or there's a lot of stigma for me to approach my employer and talk to them about the fact that I'm not really handling this extra added workload at work. So, all this to say that these are issues that we all have to recognize. Job demands analyses bring a combination of the physical and cognitive factors, and we bring this together and to the table where meaningful discussions can be had. And all of it, I said this in the beginning, comes down to communication to a large extent, and having an opportunity to engage with the different stakeholders. Let people's voices be heard and be worker-centric. That's pivotal, so that you put that individual in the center and recognize their expertise as someone that knows around their journey through life and their experiences in the workplace.
Thank you, Behdin. I have a very interesting question from someone in the audience. They ask, how can an employer be proactive when they don't know the reason the employees are going on disability leave? For example, employees often ask me for an STD form to fill out without telling me what is wrong. I know they are not obliged to disclose the reason to me, or as our insurance provider will assess their case, but I can't be proactive to prevent these causes in the first place. Should I try offering accommodating them before they decide to officially go on leave? So this is like the disclosure issue. The employer doesn't know the reason for needing a leave. What can they do to help accommodate them, in a proactive way before that leave might happen, or does it need to happen?
This is an ongoing question that many supervisors ask. And my response has always been, as a supervisor, you have a certain amount of latitude and control over the situation. If this is a request for a short period of time, you don't need to know. Well, first off, you don't ever need to know what the condition is. All you need to know is what their limitations and their restrictions are, so that you can accommodate them. Then, given what control you have, you should be able to do so for a short period of time. When it becomes more extensive, when it becomes more labor intensive, when it becomes lengthier, that's when you need to start getting involved and asking questions. And that's where you're having that on-site regulated healthcare professional or a DM expert. They'll be able to assist and support you in determining how much information and in what format, and how far can you take this, right? Sometimes the nature of the diagnosis really is helpful to the regulated healthcare professional, only in as much as, unfortunately, not all healthcare practitioners fully appreciate the extent that an organization what an organization can do to help improve someone's medical condition. And so knowing the condition helps sometimes direct the nature of the care. But again, that depends upon the regulated healthcare professional, and it depends upon the role that they've been asked to play. So it isn't necessary. And I think that a lot of people leaders, a lot of supervisors really can think outside the box, at least in the short term. And that's what starts the conversation, as Behdin has identified, and that's what develops the trust. Because you can start the conversation. You don't have to complete it, but at least starting it shows that you're willing to be partaking and listening to the individual.
Thank you, Drew. Anybody else want to add anything there? We only have a few minutes left, so maybe we can jump into our fourth question a little bit here. What is the distinction between functional limitations versus diagnosis for the purpose of accommodation? So are they different types of activities? So how do they fit together? The functional limitations assessment versus diagnosis for the purpose of accommodation. Behdin, maybe you can start. Oh, Al, do you want to start?
Well, somebody else can, it's fine.
No, go ahead, Alex. I can go ahead, Alec. I'll go after you.
Okay, very briefly, and it fits right in with what Drew just said. It's so important, and I think not well enough understood. Again, there are probably people on the call who are familiar with the sort of one-line sick notes. So the sick note might be, I don't know, can't handle stress. It might be can't handle work that might cause back pain, a really short description. Well, that's a functional limitation, but the employer, the union, and the employee have a responsibility to dig into it a little bit further. And I know there are some employers who believe that unless I know the diagnosis, I won't really know how to accommodate it. But when you start digging into functional limitations, so you can dig into, well, just what is a stressful situation for purposes of this? And you can get expert advice on that, but without delving into unnecessary aspects of the details of the medical diagnosis. So I think functional limitations is a lot more possibility to using it properly than many recognize.
I think, yeah, to build on that, I would suggest that, and this is kind of me putting a healthcare cap on, is that it is not to focus so much on the medicalization or the impairment aspect of any type of diagnosis, and looking at this from the individual perspective and through that biopsychosocial lens that we use in developing the standard, meaning that we looked at obviously through the biological and medical side of it, but also through the individual, their physical health, their social supports, their well-being, and came up to an overall understanding of what are the influences of, for example, someone's injury or illness, and how does that impact them in the workplace. So they may have a diagnosis, but that diagnosis shouldn't frame the discourse around them to be able to engage in the workplace. Rather, it should be just part of the information that's used to enable someone to actively and fully engage in work activities. And it should be one that all stakeholders recognize, meaning that we look well beyond just a diagnostic model that's from the medical perspective, and look at it from a strengths-based approach, one that case management models of a variety of kinds have said in the literature, where you see essentially the cup half full, and you want to work with that individual to be able to achieve their maximum functioning, and to look at the ways that that can be done. There's lots of ways of doing that, whether it's looking at the individual perspective, what is it, the activities that they're engaging in, or that environment that they're in, and the confluence of all three really is where we should be focusing on, and that really aligns well with what is said in the standard as well.
Thank you, Behdin. I'll leave that last word with you because we're coming to the end of our hour. It's already 1 o'clock. So thank you very much, Alec, Behdin, and Drew. It was a great conversation. Hugely helpful insights. Hopefully the audience have gotten a lot from those conversations and will help them move forward on implementing this standard within their own organization. So thank you so much for your great insights. I just want to mention to the audience that we have one more webinar in this series on May 10th, where we'll have continued conversations on the labor perspective. So that'll be our last webinar on the Work Disability Management System standard, focusing on the labor perspective. So please do join us for that last session. And I just thank you, everyone, the panelists, the attendees, some information here if you want to get in touch with us. Lena Lopez is the project manager for this standard at the CSA group. If you have some more follow-up information about the details of the standard, it's available through her. Myself, director of the Center for Research on Work Disability Policy, can reach out to us as well if you have some questions or some insights you want to share with us. Thank you, everybody. Have a great rest of the day. Stay safe and well.
Okay, everybody. Thank
you.
you.
Stay safe.
Everyone.
Take
Bye-bye,
care.
Bye.
Bye, everyone.
Bye-bye.